So let's welcome Dr. Chris Williams.
All right, good morning. I'm Chris Williams, one of the pulmonologists at Mayo Clinic Health System in Eau Claire, Wisconsin. Thank you for inviting me for this conference, and excited to review a little bit about obstructive sleep apnea and specifically going over hypoglossal nerve stimulator therapy for sleep apnea. I do not have any disclosure. Some of these surgical slides and other treatment options from a surgical standpoint, I want to give credit to my ENT colleague, Dr. Connell. So these are our learning objectives. We will spend a fair amount of time on hypoglossal nerve stimulator therapy regarding what our data and a couple of updated criteria that recently came up, and also briefly go over the pediatric indications for sleep apnea. All right, so we'll start with the quiz. Anyone want to guess either of these? Well, the gentleman to your right. Yeah. No? No English buffs, literature buffs? There you go. Yeah, Dr. Sonnenberg got it. It's Charles Dickens. And the picture on the right side, to your left, is his famous character, Joe, which was portrayed in various novels, including the Pickwickian papers. So I love history, and going back to the origin of sleep apnea, before there was ever a specialty of sleep medicine, there was Charles Dickens, and he, interestingly, was very smart, of course, and observed some of the clinical characteristics of sleep-related breathing disorder even before there was a specialty of sleep medicine. If you look at Joe here, can you guys point out some of the clinical things that you see in sleep apnea patients or sleep-related breathing disorder? Obesity, yep. Thick neck, yep. And he is sleeping. Yeah, he's sleepy. And then if you kind of observe closely, look at his face. He has that ruddy complexion. Any thoughts, on any kind of sleep disorder that comes to mind that can cause ruddy complexion? Kind of an extension of sleep apnea and obesity, hypoventilation, causing, cardiopulmonary and right heart failure, and they have this, ruddy face. So it's pretty interesting. Like he was able to, look into these things even before there was sleep medicine. So Charles Dickens described these features almost more than 100 years before sleep was recognized. His famous line, "Sleep," said the old gentleman, "he's always asleep, goes on errands fast asleep, and snores as he waits at table." And like we talked about, Joe likely had cardiopulmonary. And then the 1956 article by Burwell described the obesity hypoventilation, or the Pickwickian syndrome. And 1966, Gostard described by PSG snoring and documented upper airway obstruction causing sleep fragmentation. And 1970, the first sleep clinic at Stanford, most of the initial research and data came from Stanford. And then interestingly, after that, you can see 1975 to 80, there was more than 300 articles that was related to sleep medicine. So as we all know, OSA basically is a repetitive obstruction, partial or complete, that can cause hypoxemia and underarousals. And as you can see in this clip of in dramatic OSA in REM sleep. So what happens during sleep apnea? So you can see the anatomy on a normal patient and patient with apnea. You can see the various levels of the soft palate, tongue, and the airway, significant obstruction. So we all know that the prevalence of sleep apnea is pretty high. And it's actually it's what we are seeing is pretty much tip of the iceberg. There's like a lot more patients that are under-recognized and untreated for sleep apnea, which is why I think what we as sleep providers do is really important and fascinating, where when you identify these sleep disorders and treat them early, one of the nice things about sleep apnea is you can prevent many of these complications developing over the line. So you can see like severe OSA, more than 18 million adults have moderate to severe OSA. And then as you can see on the other graph here, untreated sleep apnea, AHI more than 30 is associated with threefold increase in all-cause mortality. So OSA is bad. As you can see, the mechanisms, it can cause intrathoracic pressure swings with intermittent hypoxemia and hypercapnia and sleep fragmentation. And I can kind of look at all these complications, both cardiovascular, metabolic, and there's been association with arrhythmias, especially atrial fibrillation. And then there are newer data coming out with incidence of increased risk of even malignancy with untreated sleep apnea. So what are the treatment options for sleep apnea? So as we all know, CPAP, or continuous positive airway pressure, and Dr. Sullivan initially designed this option. It's kind of interesting. The first CPAP was using a vacuum cleaner type engine. So actually the opposite of the vacuum cleaner. He used a breathing mask and hose. And so this was the first CPAP. So interesting thing I found out in ResMed, ResMed S that we use, the S stands for Sullivan. So this was the first study of using a CPAP for 3 consecutive nights. And so what they used was fiberglass cast of their noses connected to an air pressure device through tubes and silicone devices. So I guess this is a little more uncomfortable CPAP than what we have right now. So CPAP is a first-line option, is a great option, but the challenge is, as you can see this Cleveland article, almost like 46% of patients diagnosed with sleep apnea, after 3 years, they are not compliant with their CPAP. So what do you do, or what do we offer for these patients? You can see there are other options like weight loss, which can help with mild sleep apnea, but again, with moderate to severe sleep apnea, it can improve, but they still have ongoing sleep apnea. We have dental appliances and then various surgical options, and we will go over these options. And so I'm going to focus mostly on the hypoglossal nerve stimulator. So it's an FDA-approved device that works by an impulse through a tunnel lead that ends up with the cuff surrounding the hypoglossal nerve. Various devices have been tested in clinical trial, and we're going to specifically review about Inspire, which is an FDA-approved device for this use. So what does Inspire look like? It's kind of a brief schematic of that. So basically you have the generator here, and then you have your sensing lead and the stimulation lead. And then the only thing external the patient will be using to control the Inspire device is using this remote. So what kind of mechanisms with the upper airway muscles that Inspire works? Upper airway patency, like some of the previous pictures that we looked into, maintained by contraction of upper airway dilator muscles. And then the main muscle is the genioglossus, is innervated by the hypoglossal nerve, which is the cranial nerve 12. So if you look at the upper airway, it is a dynamic flexible tube. So that's when the airway collapse happens at multiple levels. So some of the other surgical options which we're going to talk about, the challenge is it's a multi-level surgery. So with Inspire, we're going to look into some of the criteria. So I'm going to skip this slide real quick here. So when you are having a patient that's not able to tolerate CPAP and they're interested in Inspire, so what are the criteria that we're going to evaluate them for? So the first question is they need to have moderate to severe sleep apnea. So that means the AHI between 15 to 100. So it used to be AHF between 15 to 65. So the FDA recently upgraded that last year in June. So keep in mind, though, not all of the insurance companies have adopted this new update. So some of them are still, using the older criteria. And then the BMI used to be 32 to 35 for some of the insurances, but now with the newer criteria, it's up to 40. And then Inspire is used for obstructive sleep apnea. So if you have someone with more than 25% central sleep apnea, so that is not recommended. And then as we going to look into this circumferential collapse. So one of the criteria when patients meet all of these other criteria, they need to undergo this drug-induced sleep endoscopy. So where you need to see basically no circumferential collapse. We need to see anterior posterior collapse. I'll show you in a picture what that means. So it is like a moderate, I usually tell my patients, it's not a super big surgery. It's not a super small surgery either. It takes like about 2.5 to 4 hours. Oh, okay. Let's see. The pictures are coming. Not like I would expect. It was supposed to be a video, but anyway. So basically, when we're looking at during the drug-induced sleep endoscopy, so we're looking at two different anatomical variations. So one is the anterior posterior collapse. So those are patients that are good candidates. And then when they have a complete concentric collapse, you're seeing here, so those are not good candidates for Inspire. So in general, all the data suggests almost 90% of people have anterior posterior collapse. 5 to 10% have concentric collapse. So in our experience over the last 4 years doing close to 100 patients, I would say maybe 5 patients did not meet the criteria based on drug-induced sleep endoscopy. So again, these are some of the muscles that we talked about. As you can see, the protruder muscles, the genioglossus and the genohyoid, and then the retractors of the tongue. So the hypoglossal nerve stimulator, these are the incision placements. So previously there used to be 3 incision, but now with the newer technique, it's a 2 incision surgical procedure. It's a little more, much more quicker. And I've included some slides from Dr. Connell looking at the neck dissection for the hypoglossal nerve stimulator. And then this is where the cuff plate is placed. So you can see here. And once the cuff is placed, they check for adequate response in the OR. And this is the chest lead placement. And then after it's done, the incisions are fairly, not significant. Initially after the first month, you can see some scarring, and after that, for the most part, it looks pretty unremarkable. So this was also supposed to be a video. Okay. You can see patient over here, the base of the tongue on the palate without any stimulation. Again, you can kind of look at the anatomy, the upper airway collapse causing obstructive events. And then with mild stimulation, you can see the base of the tongue opening and the palatal opening with Inspire. So the other common question people ask, what are the complications? So in general, the complications are pretty minimal. Common things include initially patients can have tongue muscle weakness or what we call tongue fatigue, and infection, low risk of bleeding and pneumothorax, and then also potential concern for improper lead placement. That's why it's tested intraoperatively. So briefly, this is another device that's available. Again, it's called as a Genio device. So basically, it's an external device with no. It's bilateral stimulation, but does not sense respiration. So again, there are some early cases looking into it, but we don't have any solid data yet. So that was interesting. What are the other things out there? So briefly, before looking into the Inspire data, what are the other surgical options? And Dr. Sonnenberg, feel free to correct me if I. say something incorrectly because this is my ENT colleague. I got some slides from him looking at what are the other surgical options. We have the UPPP. Overall, the data UPPP is not the greatest. Part of the reason when I talk to my ENT colleagues is some of the older studies where the patient that they selected were not the greatest, but we don't really do that many UPPP anymore because of the poor outcomes. And then pharyngeal palate surgery, as you can see, the surgical success, depending on the patient selection from stage 1 with the BMI of less than 40, you have like an 84% success. But then if you keep going with a higher BMI, the success is poor for pharyngeal and palatal surgeries. So just want to briefly mention about this expansion sphincter pharyngoplasty. So mainly because, this is basically a modification of UPPP using bilateral palatopharyngeal muscle flaps as a palatal sling. The reason I'm interested in this option is for those patients who are not candidates for Inspire based on their DICE, if they have circumferential collapse. So when you do this procedure, there is a high chance that we could potentially convert them to anterior-posterior collapse. Again, this is still in the early stages of research, and so we started. We have a few patients. We started, doing this, and are seeing pretty good outcomes. So basically, when you have the lateral, oropharyngeal collapse with this, ESP procedure. So this study looked at the pre-op AHI using comparing ESP to UPPP. See the pre-op AHI, the apnea-hypopnea index was 44, and then post-op was 12, and then UPPP was 20%, and the success rate was fairly high compared to the UPPP. And this was the interesting data from hypoglossal nerve stimulator standpoint using this surgical option. When patients have complete concentric collapse, these were, again, 20 patients with concentric collapse who were initially not a candidate for Inspire because of that. And then all of them, after the procedure, converted to Inspire candidacy, and they had anterior-posterior collapse. So again, this is kind of an adjunct option to think about when your patients are not meeting criteria due to the anterior-posterior collapse, then we can potentially consider this as an option. And the other surgical option, which is kind of the last and the most invasive option that we offer for patients with refractory sleep apnea that we've explored all other options, is a maxillomandibular advancement device. So we usually send these patients to our surgical colleagues at Rochester, Mayo. These are very complicated, multi-level surgery that requires at least 3 to 5 days post-operative, stay in the hospital. So interesting thing is the AHI does improve from, as you can see, this study looked at AHI went down from 64 to 9. But then the challenge is it's short term. So a lot of these patients, when they followed up, they had a relapse long term. So again, the last 6 years I've been here at my hospital, I've had one patient that undergo this procedure, and he was not happy. So what about tracheostomy? So again, it's 100% curative, but I think this day and age, again, I have really not seen anybody recently using tracheostomy as an option for sleep apnea. It's more invasive. It's changes lifestyle for the patients and the family. So there are other single-level surgical options like partial glossectomy and hyoid suspension and genioglossus advancement. So let's go back to Inspire. So we talked about a little bit about criteria. So what are the data that are available for Inspire therapies? This was the initial study, the STAR trial, that was published in 2014 that looked at the long-term efficacy of using Inspire. So you can look at the graph here. So the baseline AHI was close to 30, and then the definition of good outcome based on the STAR trial was to bring down your AHI less than 15. As you can see in the first year, third year, and fifth year, you can see like a pretty good outcome less than 15, it maintained that criteria. And then also you can see that it stayed consistent through the years. So that's also a good sign that it not only is effective initially, but then over follow-up for 5 years, patient had consistent response. And then what about clinical symptoms? The Epworth Sleepiness Score, so a normal, defined as less than 10. So these patients started at 11 before therapy at baseline, and you can see 1 year, 3 year, 5 years, it consistently stayed at 6. And then Inspire has this ADHERE registry that's looking at more than 4,000 patients. So this is probably updated now, so probably more than 4,000 right now. So looking at worldwide data to look at these outcomes. It's pretty consistent. AHI, again, baseline 33, and then you can see it's down to 7.8, and then over a period of follow-up long term, it's down to 10. Same consistent results with Epworth Sleepiness Score as well. So and since then, there's been plenty of articles looking at Inspire therapy. Again, 50% reduction in AHI was stable after 6 months, and then also consistent improvement in their daytime sleepiness and fatigue. So what about the usage? Adherence or compliance? One of the biggest challenges with CPAP we found was patients initially used it, but over 3 years they had difficulty sticking consistent with it. But then, as you can see, all of these data, the comparison showed that compared to CPAP, patients consistently used their Inspire. So when we see these patients, we kind of talk to them about what are the expectations. So at a minimum, our goal is we want to decrease their AHI by 50% compared to their baseline, or less than 15 events per hour, whichever is the lowest. And then we also want to see improvement from their ESS score, decreased by 2 points. And then at a minimum of 4 hours use per night is the goal, and the expectation is to use it every night. So it is a pretty fast recovery procedure, and the battery inside there is good for 11 years. So after 11 years, we had to go back and swap the battery. It's not as big of a procedure as the initial implant. And then the other common question people ask is, what about MRI? So the newer upgraded device that all the patients have right now, there is no absolute contraindication for MRI, so they can get an MRI. The only thing is if they need a chest MRI, there's a conditional requirement. So that means you need to let your radiology team know a couple of days earlier that they have Inspire. So they just have to make some setting changes in their protocol. So, but it is not contraindicated. So procedure complications, I know earlier mentioned some slides, and this is again kind of reviewing that. So overall, just focusing on the total amount of complication is 0.43%. And then the ADHERE registry, less than 2% complications. Again, fairly well-tolerated surgery without major complications. So what are the steps when you evaluate these patients, right? So you screen the patient. So I think that's really the important things. You want to select the right patient for Inspire. So, obviously, there's a lot of information on the internet, a lot of great ads. So the one thing is we need to make sure that, so these patients, we should make sure that they have tried CPAP, really gave a good effort, and did not tolerate it. So one of the challenges I face is sometimes people want to use Inspire just because they don't want to carry their CPAP around to their cabin. They're like, well, I travel frequently, I don't want to carry a machine with me, so that is not an indication to use Inspire. And also I've had patients who did not try CPAP, did not give it a fair chance. So I would say, what's a fair trial? I would say at least a month, and at least try 2 different masks before thinking about Inspire, because we'll talk about our experience here. Because one of the challenges is some of the patients just wanted to, because of those comfort issues, they wanted to use Inspire. So that's, I think, the patient selection is real key if you want to have good successful outcome, and also defining the expectation. So the other thing is people also have this misconception that Inspire works better for sleep apnea than CPAP. So that means, they're still tired on CPAP, then I want to use Inspire. Is that going to make me feel better? So the answer is no. So CPAP effectively reduces your AHI if you're able to use it. So Inspire, again, is for patients who are not able to tolerate CPAP, because the efficacy for CPAP, is probably going to be better. Because remember, the criteria we looked at, the good outcome for Inspire is to bring down your AHI at least less than 50% or less than 15 events per hour. But you can see like a lot of patients with CPAP with good outcome, the AHI is like down to 0 or 1. So that's the other key factor when you so you should set the expectation that your sleep apnea is not going to be better treated with Inspire than CPAP. We're going to use Inspire because you're not able to tolerate CPAP. We talked about airway exam, the procedure, and then so usually after the procedure is done, 7 days, the patient comes to our ENT clinic to see our ENT colleagues to make sure all the surgical site looks okay and for suture removal, and then they come back to see me after 30 days. The reason for the 4-week delay is since it's a nerve surgery, we want to make sure everything is nice and healed, that there's no tongue fatigue or tongue weakness when they after the initial surgery. So we want to give them at least 4 weeks, and then a month later they come for the activation visit where we turn their Inspire on and teach these patients how to use it, and also give them education regarding the how much they can go up every week, like usually 1 level every week as tolerated. And then we do a 30 days a nurse check to see how things are after 4 weeks after the activation, just making sure they've at least stepped up a few levels, they're not having excessive tongue protrusion or discomfort. And if that is going well, then I see them in 2 months from the activation visit for an in-person visit. So that's where I, again, review the symptoms. So by then, by 2 months, they would have at least stepped up by 3 to 4 levels, and you should start seeing some improvement in their symptoms. And then at that time, we also do what we call as a functional threshold. Just make sure the tongue motion is not excessive. At the same time, it's good. If they meet all of those criteria, then 3 months from the initial activation, we do an in-lab Inspire titration study. So think about that, where we kind of fine-tune their Inspire setting. So we want to make sure that the setting is appropriate to bring down their AHI to a good level. So again, multi-stage approach to have a great outcome. And once we do that, and the patient is doing great, then we see them back every 6 months to a year. So what is our current data? So we had just completed our 100th case last month. So overall, you can see that the data is on 89 patients here. So baseline AHI was around 30 to 31. And then post-implant, the AHI was down to 5. You can see the median treatment AHI was 4, and then less than 15 AHI on 89% of patients, which is, again, a little better than the STAR trial, but our N is only close to 100. So we have had pretty good success with that. And then same with ESS score. Median is around you can see the average is around 9, and then post-treatment it came down to 6. And then the usage, as you can see, it's 6.5 up to 7 hours. Again, compared to CPAP, the usage looks great. And so this is our back in 2021 is when we started the program. 2024, looking at how many patients are using our through the green pathway. So what do I mean by the green pathway is when they come in for their activation, we activate them, they do the follow-up appointment, we do the follow-up sleep study, the AHI meets the criteria that we talked about, and they also meet the usage criteria. So they're basically doing great. So that's what we call as a green pathway. So as you can see from 2024, it's only we've done maybe 20 cases. So we can see our total percentage is on green pathway is good. And I had, so the bottom slide is, so this is the national average here. So 2021 national average green pathway was 64%. And then, most of the other years, between 70 to 75%. So just want to briefly mention about using Inspire for pediatric Down syndrome patients. So as you know, as you all know, that this is a challenging patient population, that they have really high incidence of obstructive sleep apnea due to their airway anatomy, due to large tongue, and also they have other cognitive dysfunction. So interestingly, these pediatric patients, I would kind of say like 50% of them with Down syndrome, if they have sleep apnea, they love their CPAP. Their usage is like 100%. The other 50% hate their CPAP. So it's kind of like 50-50. So for these patients, even with other options like tonsillectomy and other options, their outcomes were not good. So this data from a prospective center study, 42 subjects with persistently severe OSA for pediatric greater than 10. They already had their previous adenoids and tonsils were removed. And they were not able to use their CPAP or tracheostomy dependent, which is interesting. I can see their AHI baseline came down from 24 to 11, and then the ESS score came down from 10 to 5. So you can see the prevalence here. So 6,000 babies born with Down syndrome every year, and then you can see 30,000 age 13 to 17. And then almost more than half of them have AHI greater than 10. And then I didn't know tonsillectomy is not effective. It brings it down to 50%, but not as effective. So it's an interesting article, and I think it's a good option for these patients to improve their sleep apnea and also to improve their cognitive outcome. So as you can see, the criteria is age 13 to 18 and AHI between 10 to 50. And same thing about CPAP failure, and then free of complete concentric collapse. So I'll briefly mention, we have not done pediatric patients yet at our site, but I have few of adult Down syndrome patients, and also interestingly patients with other cognitive dysfunction. I have a patient with really bad stroke with cognitive dysfunction, not able to use CPAP. So there was also, so the nice thing about Inspire in these cases is either the family member or the partner can turn it on. So you don't have to show the mask on their face, so they're much more comfortable in using this. So the other subgroup population I'll mention, again, these are anecdotal experience, is patients with REM behavior disorder. You guys have seen patients with REM behavior disorder where they act out dreams. So they also have sleep apnea, right? So if you don't treat their sleep apnea, the REM behavior gets worse. But then what happens during REM behavior? They either choke their, CPAP cord around them, so they're not able to control sleep apnea, then RBD gets worse. So I have two patients with really bad RBD and sleep apnea, not able to tolerate CPAP. So when we used Inspire, again, so nothing on their face, no mask or hose to choke, their sleep apnea got significantly better, and their RBD symptoms are also significantly better. So basically, not just patients, Down syndrome patients, we have data, but then even think about your adults who have cognitive dysfunction, not able to use CPAP. I think Inspire would be a great option because the partners can turn it on and then control how to use the device. So that's kind of all the major things I wanted to share with you guys. So basically, in summary, OSA is a very prevalent condition. It's still under-recognized, and you can see it's associated with various complications. The key is identifying this earlier and treating it. You can potentially prevent these long-term complications. Again, just want to emphasize CPAP is the gold standard treatment option. You should give CPAP a fair chance, a fair trial before looking into other options. But again, a lot of people, I would say the data suggests 10 to 15% patients have difficulty tolerating CPAP, and hypoglossal nerve stimulator is a minimally invasive option to CPAP that has shown good outcomes and an improvement in usage with both objective and subjective data. And recently, it's also approved for patients with pediatric Down syndrome. So these are my question? Yes, Dr. Laura.
Okay, so excellent talk. Thank you, Dr. Williams.
Yeah.
Question is that recently the FDA
Yep. Ye- Right. So this was like, again, approved last June. So the interesting thing, again, getting into the nitty-gritty details, so Medicare and has not still approved the 40 yet, so they are still, a BMI of 35. We have started in the queue. I have like 3 or 4 patients BMI close to 40 in the process of being implanted. So I don't have any actual data on that, but anecdotally, at the VA, we had some experience in the past. VA used to implant even patients greater than 40 before FDA approved it. So not as great as lower BMI. So far, with the limited data, but it does improve the AHI, greater than, closer to 50%, but it's not as good as the lower BMI. So I think with the new approval, once we start seeing more patients and we have more data, that will kind of help us to define. My guess would be it's going to be their sleep apnea is going to improve, but I'm not sure if you're going to get as good an improvement as we have seen in lower BMI patients.
Can I make a comment?
Yeah, absolutely, yeah.
So my experience has been similar with yours in that in individuals who are being evaluated for hypoglossal nerve stimulator, and I do the drug-induced sleep endoscopy, a relatively low percentage of them end up being complete concentric collapse people. But when I got started doing this in 2019, I started doing the drug-induced sleep endoscopies on a bunch of people. I was doing it to kind of build my experience with looking at different palates and their collapse patterns, and I'd say to people, hey, we're going to do this surgery, we're doing a septoplasty, we're taking your tonsils out, whatever. I'd like to look at your airway collapse pattern. Is that okay? Oh, thanks. And what I have found personally is in the higher BMI patients, you see a lot more complete concentric collapse. So I think that even though the BMI criteria may be expanded, I think a higher percentage of those people will not be candidates because they have complete concentric collapse, which really makes it interesting. Your expansion sphincteroplasty, would that convert those people to do it, to be a candidate? I also anticipate, like I agree, Alex, I mean, with the higher BMI, more severe sleep apnea, more deposition of adipose tissue in the peripharyngeal space, they're going to be tougher patients. I expect that the outcomes in that patient population will not be as good as the 25 BMI, AP collapse pattern, HI of 15. I mean, 17, 20, those people are going to do great. But I guess I could be wrong. Time will tell.
Yeah. And I think, the key is like keeping their expectations like realistic for these patients. I mean, if not for this, their AHI is going to be still like 60, 70. At least if we bring it down to close to 20, is that better than AHI of 70 is the question. But it's going to be interesting once we implant these higher BMI patients to see what their outcomes is going to be.
Yeah, and that's another great question. Like, what? You showed some data that said, hey, if your AHI is greater than 30, your mortality is 3 times as high. And it'd be interesting to know, and this would take probably a long time to know, but we know people are going to do real well if we get their AHI less than 5. But what happens when you have somebody who has an AHI of 90 and you get them down to an AHI of 40? Like, what health benefit is that? Like, I don't think we know that, but it seems to be, I think it would help. I think it would be beneficial, but again, that'll be a question for the future, hopefully, that we'll know.
Right. And then on that point, to kind of piggyback, like all of the CPAP outcome data that we have, we don't have a robust like cardiovascular, improvement data, like, even with CPAP usage. One of the challenges is like the average, use in all of these bigger studies was like CPAP use of 4 hours. So one thing would be interesting, like as you can see, like most of the inspired data, even like the ADHERE, registry for all of thousands of patients, their usage averages like 6 hours. So it'll be interesting to also look at the overall OSA outcomes after treating their sleep apnea when they're using Inspire 6 hours, because one of the question always, comes up, we didn't see great outcome with CPAP. Is it because people are only using it 4 hours per night? So, Any? Oh, okay. Yeah. Thank you.
Thanks.
When they meet all of the criteria, we have had, like I said, in the 100 patients that we implanted, no major issues, including, Medicare. So the process usually for private insurances, again, it's kind of interesting. So some of the insurance have like their own criteria that's different. They have like modified some of the, like for example, like most of the insurance you can do a home sleep study to get qualified, except one insurance where you need to do an in-lab sleep study and have an AHI of 20, not 15, to qualify. So as long as you kind of review, so we have like a cheat sheet looking at what each insurance criteria are, and then private insurance after the DICE, we have a prior auth process, so they need to get the prior auth before that. So yeah, fairly, like I said, on Medicare, we have I would say 50% of our patients that we have implanted are Medicare patients. So yeah, so we've actually had no major issues. So currently, I don't think that's been really good from an insurance standpoint.
All right, and then there's one more question, and that is, if the patient doesn't initially qualify for Inspire due to a failed pharyngeal collapse, is it possible over time that this could change with age or maturity?
Okay, I'm assuming we're talking about the anterior posterior collapse, the DICE. Yeah, like as Dr. Sonnenberg mentioned earlier. So yeah, so some of these patients, when they have concentric collapse, so weight loss can help potentially switch it to AP collapse, and also the ESP surgery. Again, that's early data. So we have the 20 patients study that I quoted. They were able to convert to AP collapse. But I think the main thing would be weight loss and potential role for this adjunct, surgical options to see if it can be converted. Dr. Sonnenberg, do you have any other comments on that?
No,
Yeah.
I agree with that. I think that, yes, weight loss and pharyngeal surgery would be the two options that potentially could convert a person with one collapse pattern to another. I don't think like age or time or something else could change that, and I wouldn't expect it to.
I'll make two comments. If anyone has any other questions, yeah, I want to mention two more things real quick. Yes, sir.
I don't know if we have any data about this. Usually as a sleep tech, my concern with the titration, it's not the patient with an AHI over 100. It's more the patient with an AHI of 40 to 60 that's having 60 to 90 second events. That's the one the more complicated for me as a tech. Mm-hmm. Do we have any data about that kind of patient with the Inspire?
So like moderate to severe sleep apnea, like outcomes with AHI outcomes with that? Is that?
Yeah, but mainly the patient who have like the long events, so lower AHI, but they're having 60 to 90 second events.
Sure. I don't know if they've looked into like specific subgroup of long events as far as I'm aware of. Yeah, it's a great question. So I'll make two kind of comments. So the other question people usually ask is like, how many of your patients did not tolerate Inspire and had to be explanted? 2 so far. And me and Dr. Sonnenberg are discussing. So part of the reason, again, I emphasized on patient selection. So because so the one patient was absolutely tolerating CPAP well, so he just wanted to use Inspire because he thought that'll be more comfortable. But this was a patient that was that was not seen by us. He was referred directly to the surgeon. So that's kind of the challenge where you want to kind of educate them before. So that's if they're already using CPAP and comfortable with that, then Inspire is not an option. That's why I want to kind of emphasize that patient selection is key. And then the second comment is, I mentioned that 80% of patients, 80 to 85% of patients are doing great. Like, they go through the green pathway. So what are the patients who are not on the green pathway? So either they are not tolerating their Inspire settings or the AHI, is not optimal. So we have like a really nice, protocol for these patients, what we call advanced, similar to advanced PAP titration. So we have different advanced, settings like electrode configuration change, and then to improve their, comfort to use the Inspire more consistently. And then some of these patients, when they're not able to tolerate, so we do awake endoscopy-based titration, so where you kind of adjust the settings and see what their tongue motion looks like, what their soft palate looks like, and then even the next step is we can also do sleep-induced endoscopy-based advanced titration. So basically, there are these advanced titration options for patients who are challenging. Basically, that means like their AHA is not better or they're not able to tolerate the baseline settings. So in my experience, I have around 10 of those patients, and after doing multiple of these advanced titrations, I would say like 7 of them have done well. There's 3 still I'm working on. So like I said, 80% of patients, they do well, and then this other 20% are a little more challenging where you need to do this advanced titration option. So you need to kind of also discuss with them and give a realistic expectation that they could be one of them, so that so they're not unhappy later. All right, thank you all.